Okay, so I hope this evening's rather fun. So we're talking about pharmacogenes and how our drugs control our genetic metabolism of drugs, how our genes affect this. And Ann-Britt Jones is going to give this first talk. Ann-Britt is a honorary fellow of the Institute of Cancer Research. She's had a background in epidemiology, HIV, and oncology, and she actually gave a fairly large presentation across of this in the States quite recently. Ann-Britt, it's a pleasure to listen to you tonight. Thank you very much.
Well, thank you so much for having me. Hi there. Just giving this talk in a private capacity as an educational webinar, so thanks for the invitation again. I'm going to give you, can you see my slides?
Yeah.
Oh, good. So I'm just going to give you a brief overview of pharmacogenomics and the lay of the land and how it's kind of being implemented at the minute and where things are and considerations. So I'll get started. So what is it? It's the study of how genetic variation influences a drug response in our body, and there's considerable variation. And really, it's how can we use it to harness efficacy, so making our treatments more efficacious, and also improve patient safety. So genetic factors in patients are the pharmacokinetics, and that's an old medical school one of the ADME. So what does the drug do to a body? And we're talking around when you take the medicine, absorption, how will it get in? Where will it go? The distribution, where will it go? Are the transporters going to be saturated? Are they going to be distributed evenly? We're talking about the metabolism. Where is it broken down? And is that being interacted by anything else? And also excretion, and how do we get rid of it? And then pharmacodynamics, which is traditionally thought of what the body does to a drug or the biological response the body has to a drug. And in that come out adverse drug reactions. And that's our main concern, as well as efficacy. Oops, sorry. So put it into context. We know that the number of prescription in the UK is rising. We've got polypharmacy, an aging population. And older data from about 18,000 patients in the UK revealed that an adverse drug response prevalence rate of about 6.5%, leading to a hospital admission rate of about 80% among cases. And over 2% of those admitted were fatal. So even without fatalities, the morbidity and the resources used within the healthcare system is substantial. And then it goes on to comparing whether preemptive testing or kind of reactive testing is useful. And preemptive testing from data in the US showed that among 10,000 patients, there was a 91% of individuals showed to have at least one actionable genotype. And this was in a small panel. So we all have something, and we could do more to help. So what's the purpose? How can we use this other factor and identify patients that are responders or non-responders to a drug or a class of drugs? And again, just avoiding adverse events, optimize the dosing of drugs, and be in a preemptive strategy. You know, we take histories from patients, we ask their age, what are the medications they're on, what their height and weight are, all the other factors, including lifestyle and diet. And we're not taking account of one significant factor, which is our genetic makeup. And we're talking about germline genetic alterations here. However, there are lots of considerations, as you can imagine, trying to implement such data into the healthcare system. There are various guidelines that differ between countries. There's a standardization and sometimes a lack of standardization among definitions and what a metabolizer is or isn't, what the nomenclature is, and the clinical scientists and caregivers or providers and pharmacists all need to be speaking from the same sheet. Again, there's drug-to-drug interaction. We know that this is possible with some of the drug inducers and inhibitors, which can affect certain drugs and interactions. And then, as I alluded to previously, patient characteristics such as renal function, or their liver function, their age, their ethnic diversity, BMI, lifestyle, and diet. So the metabolizer types, these are primarily agreed upon, and there's a list of resources I can send around. But they're into 4 categories. A poor metabolizer has a decreased drug metabolism, resulting in a side effect at standard doses, so a lack of efficacy. There's intermediate metabolizers with a slow rate of metabolism, resulting in too much of a drug at standard doses, potentially causing side effects that are deleterious. Your normal or extensive metabolizer, which has the normal rate of metabolism, as it says on the tin, and the normal amount of drug at standard doses, hopefully having the desired effect. And then an ultra rapid metabolizer, where a drug is rapidly broken down and may be removed from the individual system too quickly, therefore lacking effectiveness. So this is just a brief list of actionable germline genetic variation alterations and associated medications. The NHS is looking at putting at 40 genes into testing at the moment. And a lot of these you can see are very relevant to general practice. So I'll be talking briefly mainly about some of the CYP alleles or variants, and we're going into kind of anything from pain medication to psychiatric to neurocognitive, and also immunosuppressants or cardiovascular disease, as well as into the HLA domain. And I'll give a specific case within oncology. So it's already in testing for some drugs. Just recently, in the last month, the NHS has approved testing neonates with a swab for gentamicin sensitivity to prevent sensory neurohearing loss. So they think that in doing this, they can prevent about 1 in 800 cases of babies losing their hearing. This is mitochondrial DNA. And it was a study done up in Manchester, as I said, with easy oral or nasal swabs. The turnaround time is very quick. And then, as we know, neonatal infections are quite common, and you can avoid giving gentamicin in those that have this variant and protecting their hearing. So that's a wonderful thing that's being instigated nationwide. And then certain areas have instigated some HLA testing, related testing. DPYD testing for chemotherapy-related toxicities has come into use in the last few years. And on the horizon is the CYP 450 domain, which I'll give some examples. So we'll take each one in turn. The cytochrome P450 family is an abundant family of enzymes in the liver that actively metabolize exogenous and endogenous substrates. And of the 57 CYP genes, 8 are responsible for metabolism of most of the drugs in clinical use. And through the studies we've done here, we can see a lot of them are quite familiar. It's highly polymorphic, so it changes a lot. It changes depending on ethnicity, so it's ethnicity specific, and can have a big impact. The first one is the CYP2D6, and polymorphisms within this enzyme allele significantly affect the pharmacokinetics of about 50% of the drugs in clinical use. And consequences of that can either be no drug response or adverse drug reaction. They distribute significant intra-ethnic differences, so that's one thing to consider. And they affect things such as codeine, antidepressants, and tamoxifen, for which there's over 80 alleles of. And with codeine being a prodrug, there have been studies in the past questioning whether you should be testing again in the neonatal period after birth when moms are being given codeine during the antepartum and postpartum in terms of cause for respiratory distress in infants. So it is significant for adults and children. Another important CYP P450 enzyme is CYP2C19 and clopidogrel. This is a hot topic among the cardiology domain, and studies have shown that the presence of such an allele, specific allele, the STAR2 allele, in patients on pidogrel post-percutaneous coronary intervention incur a significantly higher risk of adverse cardiovascular events, including stent thrombosis. So in wanting to say, can we prevent thrombosis and excess bleeding, is there a point of care test that we can do to genotype all new patients with an acute indication for this antiplatelet medicine. The question with all of this is, making sure we ask, will identifying the poor responders and offer alternative therapy result in better patient outcomes? And I think that's why there's been a slow uptake into the clinical actual practice of this, even though all the data is there. And the other thing is, is it simpler and cheaper just to do the genomics testing and have a panel out for everyone, or just to measure the effectiveness of clopidogrel through what we now use, which is the platelet reactivity test, which is cheap and simple? So these kind of questions will come up, as you can imagine, as we go through any of these implementation of pharmacogenomic testing. Then we'll switch gears a little bit to the HLA domain, which is the human leukocyte antigens. So these are expressed on our cells to identify self from non-self. It's on the short arm of chromosome 6, involved in the pathogenesis of immune-related adverse drug reactions. There's over 200 genes. And as you can remember, maybe from med school days, divided into 2 classes. And also associated with more than 100 diseases, such as Spawn and things like that. So what are we worried about specifically? Well, there are 2 severe reactions that can, HLA-related reactions, Stevens-Johnson syndrome and toxic epidermal necrolysis. The first of which doesn't involve any mucous membranes, and it can, patients need to be hospitalized. It can cause death. With TEN, you get involvement of the mucous membranes, and over 30% of the body is affected. And these have been specifically associated with 2 types of HLA-B, 5701 and 1502, which I'll talk about just now. So these are important for us because of the morbidity and mortality associated. They may be rare, but extremely threatening, life-threatening. So the presence of the HLA-B 5701 really came about back in the early HIV treatment time with abacavir, which is a non-nucleotide reverse transcriptase inhibitor, which was found to be associated with its delayed hypersensitivity reaction. It was so specific, and the studies were just outright the evidence there that the testing had been introduced in the NHS since 2005, preventing all of this. So if you get a patient that comes in that needs that treatment, they get it tested right away. If that's present, they don't get a abacavir within their triple therapy or combination antiretroviral therapy. It's also been found that HLA-B 1502 allele has been highly associated with carbamazepine. And as you know, that's a widely used drug, not only for bipolar, but for trigeminal neuralgia and epilepsy, and it can induce Stevens-Johnson's and TEN. It's associated mostly with the East Asian population. However, it has not been mandated by the NHS as of yet. It is being used and implemented in testing in the States. Finally, I'll give an example in the oncological world of DPYD testing. So dihydropyrimidine dehydrogenase is an enzyme encoded by the DPYD gene. It detoxifies 5-fluorouracil and other oral prodrugs such as capecitabine and tegafor, which are used in about 15% in the treatment of cancers such as breast, colorectal, stomach, and bladder cancer. A deficiency in this increases the risk of the fluoropyrimidine-induced toxicities, and up to 30% of patients experience severe toxicity. And I'll just give an example. What are the toxicities? So neutropenia, low white count, severe diarrhea, necessitating hospital admission, mucositis, hand-foot syndrome, which is a palmar plantar erythema, which is quite painful and no real treatment for it. And it has been shown that about up to 1% of patients, this toxicity can be fatal. So what can we do to prevent or kind of predict these associated morbidities? To put it into context, I'll just give a little example. So there's a 60-year-old gentleman who presented with bladder cancer. He's of Middle Eastern origin. He started with traditional treatment for his staging of neoadjuvant chemotherapy with the platinum and gemcitabine, and he was fine. He sailed through it. no toxicities or side effects. As per treatment guidelines, he declined surgery but opted for chemoradiation, which was given a 5-FU, which is a fluorosil, and mitomycin alongside radiotherapy. After 5 days of the 5-FU, the fluorouracil, his counts showed a profound neutropenia and a thrombocytopenia. We did DPUID testing, which didn't demonstrate any mutations. So what's got to make you think about a couple of things that I think encompass all parts of pharmacogenomics is, was there another area that we're missing? So is there another pathway that the enzyme is the drug's eluding, that the enzyme is not working as well? Or did we get the right variant? So DPYD testing was introduced in the NHS in 2020. It's associated with 4 main variants, and the NHS is doing about 40,000 tests per annum at the moment, but they're not doing other genes such as thalidomide synthetase that affects that metabolism. And also these 4 main variants are ethnicity specific, so mainly in European or Caucasian populations. And this just goes on to show a little bit more examples within the oncology realm. I guess to note, tamoxifen within the CYP domain is not being tested regularly. For irinotecan, the toxicity in the UGT1A 1A1 is being tested for in the States for the time being. And then this is another one that the TPMT genomic testing has not been introduced yet in the UK, and it does have overlap for some of the other inflammatory bowel diseases, as you can see, or rheumatoid ones in terms of treatment with azathioprine. So how do we do it? How is all this going to happen? It's a lot of information, a lot of different things. Well, ideally, we obtain a genetic profile, determine the genotype, sequence it, assign a phenotype, an extensive metabolizer, poor metabolizer, and then use this report and make decisions about medication. And it is happening. So the All Wales Genomics Service is doing a pilot study with some GPs and over about 300 patients testing clopidogrel. So they're identifying patients who need clopidogrel, testing them, sequencing, getting the result, and then the result is either given back with the GP or a local pharmacist to see how that goes. So that is in progress in Wales as we speak. However, there are many caveats with anything, with any kind of new and exciting tool that we can implement. There's variation in interpretation and definitions. I've kind of alluded to that earlier. There's a lot of consortia databases that are being amalgamated together because information from research lab, clinical scientists, clinicians, and commercial labs need to be amalgamated together and sorted through so people can, it's great to have the data, but how are we going to interpret it and apply it? And I think we found that in some of our studies. We can't forget about patient characteristics, but at the same time, as I said before, there's so many polymorphisms that we could be taking account of, just like we take account of other age-related characteristics and co-medications, etc. And then implementation, when to test. Should we test at point of care? Is it preemptive testing? Is it afterwards? Is it during the acute event? What kind of test is it going to be? Is it going to be gene specific, or the cost of genome sequencing and next generation sequencing has come down so much now that let's just do a panel and instead of just gene specific. And then of course the infrastructure, who's going to test? Is it the pharmacist? Is it the general practitioners? Who's going to give the test result back? And who's going to be responsible for that? And then cost comes with it. And then finally, education. We need to educate ourselves as clinicians and healthcare providers, but also clinical scientists and further down the field. And that is a quick run through, albeit of application of pharmacogenomics for now. Thank you.
Thank you, Abrit. AB, that's so kind. Really appreciate just giving us quite a detailed feel in some areas of pharmacogenes, and it's fascinating to see how you produce that set of slides. Thank you very much. And